Hello, I'm Dr. Marla Shapiro. I'm a former president of the North American Menopause Society, and I'm thrilled today to be here with Dr. James Thew, who is the 2018-2019 president of the North American Menopause Society.
Glad to be here, Marla.
Tell everybody what you do.
Well, I'm a reproductive endocrinologist, so I work with hormones in both reproductive age women and menopausal women.
Now, let's say I'm early sort of perimenopausal, mid to late 40s, maybe early 50s, and I come see you or my healthcare practitioner, and I want a bone density. I specifically say, I'd like a bone density. How are you going to address me?
Well, I think bone density is an important component of health care as a preventive measure, and it's a screening test. So what I would do is some additional screening before saying that you do need a bone density test in order for insurance, for example, to cover it. So if you're low body weight, or you have had a history of eating disorder, or you've had a relative that has had a hip fracture at a relatively young age, or if you're on a type of steroid called glucocorticoids, prednisone or cortisone acetate are two common ones that are given for like lupus or rheumatoid arthritis. So those individuals are at particularly higher risk for having low bone density and could be at risk for fracture at a very young age.
And if I don't have those risk factors, when should I be having a bone density?
Generally, the recommendation is at 65 that a baseline bone density be done. And then if there are findings from that, a follow-up study might be done in 2 years or 3 years.
For the longest time, I've heard that women get bone densities at a young age and then they get put on medications that they may not really need. Why does that happen?
Well, sometimes clinicians don't look at the intent to treat type of summary that is available through either North American Menopause Society or National Osteoporosis. So these are things that clinicians should pay attention to as to is it appropriate to treat someone even if they have a borderline bone density or a lower bone density than expected.
So how is a bone density done? When I go for my test, what can I expect?
So basically it's a low energy x-ray. You're on a table and the camera just takes a picture of your spine and then they put a special brace on your ankle so that your hip is turned a certain way and oriented, and they take a picture of the hip joint. And then the machine can then calculate the amount of density or amount of calcium that's in the bone itself. And that's an indirect measure of how strong the bone might be, and it can predict your fracture risk.
Is it important when I go for my next one? Well, firstly, when should the next one be?
Well, in general, we recommend no more than 2 years, or no less than 2 years, I should say, because there is some variation from study to study, even on the same machine.
And does it make a difference, having said that, if I decide, no, I want to go somewhere else? Will there be a difference between one machine to another, or is a test a test a test?
There are differences, and the calibration of the machine, although maybe similar and even the same brand, can vary from machine to machine. So there is, the variation is such that to make a clinical decision, it would be better to do it on the same machine at the same site.
And are there times where a bone density for me as I get older may not be as predictive of my risk as other times?
Certainly. As you get older, you might have arthritis in your back, you might have spondylosis and some other diseases that cause calcium to accumulate in the spine area. In that situation, the higher bone density doesn't predict that you have normal bone strength, and the hip area is actually the better area to actually survey and make that decision.
So I think what I'm hearing from you, and as a woman who is a patient looking to my healthcare provider, is that sometimes doing a test too early is just too early.
That's right, and sometimes it doesn't give you enough information to really make a clinical decision. So screening tests are relatively sensitive, but not necessarily as useful if it's done too soon.
And I think the bottom line to women listening to your messaging is that screening talks about a population generally, whereas that one-on-one decision based on those risk factors that you mentioned may be guiding your advice a little bit differently. So as a woman, having individualized discussions with someone like you is critical.
Right. And remember, we're not treating a number, we're treating a patient.
Right.
And with that patient comes a history of her prior lifestyle, prior events like eating disorder, or her body habitus if she's very thin.
Smoking, alcohol.
Smoking, exactly.
All of those things. Thank you so much for being with us.
Thank you.